Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. We'll present today the two different approaches and the way you look at it. So looking to the high frequency stimulation in two approaches we do commonly in the cochlear implant, which is the cochleostomy versus the round window. In old ages, when we started our cochlear implant program, all of us used to do cochleostomy, and then recently everybody's doing now or trying to do the round window membrane. Disclosure, I have nothing to disclose, in spite of I'm going to talk about one brand and one electrode. Round window insertion, it's well known. It's just like a minimal incision through the round window, and then it's smoothly you can introduce your electrode, which is really soft surgery, atraumatic to the inner ear structure. The advantages of round window is ensure that we inserted our electrode in the scala tympani. It's less traumatic to the residual functional spiral neural ganglion, and no need for drilling in the cochlea to reduce the possibility of bone fragments. Having said that, actually sometimes we have to make a little bit of drilling in the cresta area or the inferior part where you have a little bit of narrowing while putting the electrode. Keeping in your mind the round window is a side window, is not like a straight window in the scala tympani. The round window insertion is associated with the scar formation at the round window, so actually it will affect the mechanics of the inner ear, and this is why it's one of the drawbacks. It's difficult approach sometimes in some cases. Not all cases you can visualize the round window. Some slim cases you will have difficulty to find the round window niche and the round window membrane. Cochleostomy is our old technique, and we used to do cochleostomy all the time. And looking to our, we used to drill in the overall promontory or the inferiorly or anteriorly inferiorly. We're looking to our results when we started in the 90s, and we're looking to our patients. They were doing fine, and then we started to do round window, and still they are doing fine. So we would like to see whether there is a real difference between put some sort of an evidence, there is a difference between round window and oval window insertion. The round window, the cochleostomy, you know that usually there is an extrusion is higher, risk of damage of a spiral ganglion, there is the bone dust, and there is a drilling which can affect the cochlea from inside. And there is always a debate between round window and cochleostomy. I understood that most of the people now is doing round window. The cochlear duct at the lower basal turn is the widest area. So we choose the lower, how to make some sort of an evidence on this region. So we tested the high frequency, which is the basal turn, and looking to the impedance and the MCL at that last four electrodes, which represent the high frequency stimulation. So our methodology was that we have inclusion criteria. We used the round window, a profound bilateral, unknown cause of deafness, normal cochlear anatomy, same implant device, same electrode, full insertion, and 1 year follow-up. Exclusion criteria was any cochlear anomalies, any other implantable device, incomplete insertion, or post-meningitic cases. Our results. So we got like 31 patients, 16 were cochleostomy, 15 were round window. The mean age was 8.7. Male and female were distributed almost equal. Most of them actually were below the age of 5. Because of the MCL, but there were some sort of skewing when we get like a patient of 15 years old and patient of 13 years old. If you look to the impedance, which will represent the last four electrodes in the Lasford contact, which will represent the stimulation of the high frequency, we found that the impedance is higher. You know, the violet is the cochleostomy and the white is the round window. There was a higher level, and it goes higher when you go more basally. If you look to the MCL after 1 year, you know, when everything is stable now, we found that the cochleostomy, which is the blue one, it gets a higher number from the round window, and it gets higher when you go more basally. So when we did the statistical analysis, there was no significant difference between the two techniques in terms of impedance and MCL. Likewise, superiority of round window insertion regarding MCL in all 4 basal electrodes. The impedance and the MCL value gets slightly higher as we go more basally, in parallel to increasing radial distance. So probably the electrode usually maybe goes a little bit away from the modulus. Suggests the influence of electrode model interface upon fibrosis and inflammatory process, because this is the widest area of the. So in conclusion, we find suggests likely superiority of the round window, in spite of there is no statistical significance, but does enable generalization. We cannot generalize these results. We need to have more samples. We need to have more patients, so at least we can make some sort of an evidence-based that round window is really help the patient more than the cochleostomy. Thank you.